Picture a 24-week premature infant, barely 500 grams, whose survival depends entirely on your nutritional decisions in the next 24 hours. Every calorie, every gram of protein, every milligram of minerals you provide will determine not just whether this baby survives, but how their brain develops, whether they'll walk, talk, and learn normally. This is the profound responsibility of neonatal nutrition, where clinical precision meets human potential. The decisions we make in those critical first days echo through a lifetime. Consider this sobering reality. Premature infants are born in a state of nutritional crisis. Unlike any other patient population, these tiny humans face immediate starvation at the cellular level. Their bodies cannot wait for adequate oral intake or feeding readiness. Every hour of nutritional deficit accumulates into developmental debt that may never be repaid. The stakes are clear. Master these principles or watch preventable disabilities unfold before your eyes. Gastrointestinal development follows a precise timeline that determines feeding capabilities and nutritional management strategies. Fetal swallowing begins early, at 8 to 11 weeks gestation, establishing the foundation for future feeding reflexes. Intestinal transport systems develop sequentially in a predetermined pattern. Amino acid transport mechanisms mature at 14 weeks gestation, allowing protein absorption. Glucose transport pathways develop at 18 weeks, enabling carbohydrate utilization, and fatty acid transport systems emerge at 24 weeks, permitting fat absorption. However, functional digestive capacity remains severely limited until 28 weeks gestation, explaining why infants born before this threshold face such significant feeding challenges. Amniotic fluid exposure proves critical for proper gastrointestinal maturation. The fetus swallows amniotic fluid containing growth factors, hormones, and nutrients that stimulate intestinal development and prepare the gut for postnatal function. This developmental timeline explains why premature infants require specialized nutritional approaches. Their interrupted gastrointestinal development means normal feeding mechanisms remain immature, digestive enzyme production is insufficient, and absorptive capacity is dramatically reduced compared to term infants. The neonatal gastrointestinal tract serves two primary functions that determine survival and health outcomes: digestion and absorption of nutrients to support growth and development, and serving as an immune barrier against pathogens in the extrauterine environment. Preterm infants face dramatically increased risks across multiple gastrointestinal domains that compromise both functions. Altered mucosal immunity results from interrupted development of gut-associated lymphoid tissue and immunoglobulin production, leaving these infants vulnerable to infections and inflammatory conditions like necrotizing enterocolitis. Abnormal bacterial colonization occurs because premature infants typically receive antibiotics and lack early breast milk exposure, leading to dysbiosis with predominance of pathogenic rather than beneficial organisms. Decreased digestive enzyme production affects all major nutrients. Pancreatic lipase deficiency impairs fat digestion. Lactase deficiency prevents lactose breakdown, and reduced bile acid production compromises fat emulsification and absorption. Limited gut motility stems from immature migrating motor complexes and delayed development of coordinated peristalsis, resulting in feeding intolerance, gastric residuals, and increased necrotizing enterocolitis risk. Enteral feeding becomes crucial because it stimulates hormonal regulatory mechanisms essential for gastrointestinal development. Gut hormones promote motility maturation, nutrient contact with intestinal mucosa triggers enzyme production, and luminal nutrition supports development of tight junctions that create effective barrier function. Without early enteral stimulation, the gastrointestinal tract remains developmentally arrested. Parenteral nutrition toxicity increases, and the risk of life-threatening complications escalates dramatically. The gastrointestinal tract develops according to a precise timeline that determines feeding capabilities. Swallowing begins early at 11 to 12 weeks gestation, but this primitive reflex bears little resemblance to coordinated feeding. Non-nutritive sucking emerges at 18 to 24 weeks, You'll see these tiny infants making sucking motions, but they lack the strength and coordination for actual nutrition. Propulsive motility doesn't develop until 30 weeks, which explains why 28-weekers often have feeding intolerance and gastric residuals. The migrating motor complexes that create coordinated intestinal contractions finally appear around 33 weeks. Most importantly, nutritive sucking, the complex coordination of suck, swallow, and breathe, doesn't mature until 34 to 35 weeks gestational age. Premature birth disrupts this developmental sequence, leaving infants with impaired function across multiple systems. Low bile salts and pancreatic lipase create fat malabsorption. Decreased lactase activity persists until term gestation. Delayed gastric emptying leads to feeding intolerance, and overall decreased absorption affects every nutrient we provide. Birth weight classifications provide critical risk stratification that guides immediate and long-term care decisions. Low birth weight infants below 2,500 grams, very low birth weight infants below 1,500 grams, and extremely low birth weight infants below 1,000 grams each represent progressively higher risk categories with distinct nutritional needs and complications. Size classification requires appropriate growth curves, the Fenton curve for preterm infants, and World Health Organization or Centers for Disease Control curves for term infants. These classifications define small for gestational age as weight below the 10th percentile, appropriate for gestational age as weight between the 10th and 90th percentiles, and large for gestational age as weight above the 90th percentile. Intrauterine growth restriction represents a specific diagnosis of poor fetal growth that carries significant implications. Symmetric intrauterine growth restriction occurs during the second trimester, resulting in proportional reduction of weight, length, and head circumference with a normal ponderal index, essentially a proportionally small but well-formed infant. This pattern typically associates with chromosomal abnormalities or congenital anomalies that affect overall growth potential. Asymmetric intrauterine growth restriction develops during the third trimester, creating infants with low weight but normal head circumference, low normal length, and characteristically low ponderal index. These infants demonstrate features of malnutrition with wasted appearance, loose skin, and minimal subcutaneous fat due to placental insufficiency that limited nutrient delivery during the critical final growth period. Understanding these distinctions guides nutritional planning, as each pattern suggests different underlying pathophysiology and different approaches to nutritional rehabilitation. Anthropometric measurements serve as critical diagnostic and prognostic indicators in neonatal care. Weight loss exceeding 15% of birth weight within the first week of life in premature infants represents a clinical threshold that distinguishes normal physiological adaptation from pathological dehydration requiring intervention. Preterm neonates exhibit increased transepidermal water loss due to immature skin barrier function and limited subcutaneous adipose tissue, while simultaneously possessing minimal glycogen and fat reserves at birth. Standardized growth metrics, particularly Z-scores, provide objective assessment tools for monitoring neonatal development trajectories. A decline in weight for age Z-scores from +0.25 to -0.8 indicates significant deviation from expected growth patterns and correlates with increased risk of adverse neurodevelopmental outcomes. This degree of early postnatal growth restriction has been associated with compromised brain development, as adequate nutrition during the critical period of rapid brain growth is essential for optimal neurological development in preterm infants. Linear growth measurements provide more stable indicators of nutritional status and developmental progress than weight-based metrics in neonatal populations. Unlike body weight, which demonstrates significant variability due to fluid balance changes, medication effects, and normal physiological fluctuations, length measurements reflect underlying protein synthesis rates and skeletal development with greater consistency over time. Weekly linear growth increments serve as reliable indicators of anabolic processes, including muscle protein accretion and bone mineralization. These measurements correlate with the efficiency of cellular metabolic pathways responsible for tissue synthesis and organ maturation. Head circumference measurements carry particular clinical significance as markers of brain growth and development, given the rapid pace of neurogenesis, synaptogenesis, and myelination occurring during the neonatal period. The precision of anthropometric measurements is critical for accurate assessment of growth velocity and early identification of growth restriction. These standardized measurements enable clinicians to monitor developmental trajectories and implement timely interventions when growth parameters deviate from expected norms, potentially preventing long-term developmental complications. Laboratory monitoring provides the objective data that guides nutritional decision-making in ways clinical observation cannot. Bone health monitoring centers on 3 critical values: alkaline phosphatase levels above 500 to 800 international units per liter signal osteopenia development, while serum phosphorus below 4 milligrams per deciliter suggests poor bone mineralization. Calcium levels must be monitored alongside phosphorus to maintain appropriate ratios. Nutritional status assessment relies on total protein and albumin levels to evaluate protein sufficiency. These values reflect the body's ability to synthesize proteins from our nutritional interventions. Triglyceride levels below 200 to 250 milligrams per deciliter indicate appropriate lipid tolerance, helping us determine safe advancement of intravenous fat emulsions. Essential fatty acid status becomes critical when infants receive prolonged parenteral nutrition. We monitor triene to tetraene ratios and MEAD levels because essential fatty acid deficiency can develop within 72 hours without adequate lipid provision. Since we began providing early, aggressive nutrition with amino acids, hypophosphatemia has emerged as a common complication. When infants enter anabolic states, their cellular machinery consumes phosphorus for ATP synthesis faster than we can replace it, creating a refeeding type syndrome. Parenteral nutrition serves as a critical therapeutic intervention designed to provide essential nutrients when enteral feeding is contraindicated or insufficient in neonatal populations. This intervention utilizes a combination of crystalline amino acids, dextrose solutions, and lipid emulsions to meet the metabolic demands of preterm infants during periods of rapid growth and development. Early initiation of parenteral nutrition, typically within the first 24 hours of life, is essential for maintaining positive nitrogen balance and preventing protein-energy malnutrition in high-risk neonates. During this critical period, metabolic processes are highly dynamic, with cellular machinery rapidly transitioning between anabolic and catabolic states based on substrate availability. Delayed nutritional intervention can result in negative nitrogen balance, leading to protein catabolism and compromised growth outcomes. The timing of parenteral nutrition initiation is based on physiological evidence, demonstrating that preterm infants possess limited endogenous energy reserves and elevated metabolic requirements. Clinical guidelines emphasize early nutritional support to prevent the metabolic consequences of prolonged fasting, which include increased protein breakdown, impaired immune function, and suboptimal neurodevelopmental outcomes. Energy requirements in parenteral nutrition follow a precise escalation that matches the infant's evolving physiologic capabilities. On day 1 of life, when stress hormones surge and organ systems struggle with extrauterine adaptation, extremely low birth weight and very low birth weight infants need only 40 to 50 kilocalories per kilogram daily, combined with a minimum 2 grams per kilogram of protein to halt catabolism. During the transition phase from day 1 through 7, as kidney function stabilizes and metabolic demands increase, extremely low birth weight infants require 75 to 85 kilocalories per kilogram, while very low birth weight infants need 60 to 70 kilocalories per kilogram. Both groups require 3.5 grams per kilogram of protein during this critical period. Once infants reach the growing phase, after 1 week of age, energy needs climb dramatically. Extremely low birth weight infants need 105 to 115 kilocalories per kilogram daily, while very low birth weight infants require 90 to 100 kilocalories per kilogram. Protein requirements remain high at 3.5 to 4 grams per kilogram for extremely low birth weight infants. The energy distribution should target 50 to 60% from carbohydrates, 25 to 40% from lipids, and 10 to 15% from protein to optimize utilization. Protein administration constitutes a fundamental component of neonatal nutritional support, serving as the primary substrate for tissue synthesis and growth. The amino acid compositions utilized in parenteral nutrition formulations differ significantly from the protein profiles found in human milk, representing synthetic alternatives designed to meet specific metabolic requirements in clinical settings. Extremely low birth weight infants demonstrate elevated protein requirements, typically requiring approximately 4.0 grams per kilogram per day, compared to 2.0 to 2.5 grams per kilogram per day for term infants. This increased requirement reflects the accelerated rates of protein synthesis necessary to support rapid somatic growth, organ development, and tissue accretion during the critical postnatal period. The enhanced protein needs in preterm populations are attributed to several physiological factors, including higher baseline metabolic rates, increased protein turnover, and the necessity to achieve catch-up growth while maintaining normal developmental trajectories. Adequate protein provision is essential for supporting lean body mass accretion, immune system development, and optimal neurodevelopmental outcomes. Clinical protocols emphasize precise protein dosing to achieve positive nitrogen balance while avoiding potential complications associated with excessive amino acid administration. L-cysteine reveals the exquisite vulnerability of premature biochemistry. In the term infant, the enzyme cystathionase performs its molecular choreography effortlessly, converting the thionine to cysteine to taurine in an elegant metabolic cascade. But in the premature infant, this enzyme sleeps, leaving a critical metabolic pathway broken. Without L-cysteine supplementation, protein synthesis stalls, calcium and phosphorus remain insoluble, and the infant's acid-base balance tilts toward dangerous territory. This single amino acid represents the difference between effective parenteral nutrition and biochemical chaos. Yet, its addition comes with the price of acidosis, a perfect example of how neonatal nutrition demands constant balance between competing physiologic needs. Glucose infusion rates represent the foundation of metabolic support, with specific ranges that balance neurologic protection against metabolic complications. Term infants require an initial glucose infusion rate of 4 to 5 milligrams per kilogram per minute, while preterm infants need higher rates of 6 to 8 milligrams per kilogram per minute due to their increased metabolic demands and limited glucose storage. The absolute minimum glucose infusion rate of 4 milligrams per kilogram per minute must never be violated. This represents the brain's non-negotiable requirement for glucose substrate. Even when hyperglycemia develops, reducing below this threshold risks profound neuroglycopenia. Advancement should proceed cautiously at 1 to 2 milligrams per kilogram per minute daily, based on serum glucose tolerance, targeting a final goal of 8 to 12 milligrams per kilogram per minute. Exceeding 12 milligrams per kilogram per minute creates problems. Glucose oxidation pathways become saturated, excess glucose converts to fat through lipogenesis, and carbon dioxide production increases, potentially complicating respiratory management. Each gram of dextrose provides 3.4 kilocalories, making glucose a concentrated energy source that must be precisely calibrated to avoid metabolic overload while meeting essential energy needs. Glucose intolerance is a common challenge in preterm infants receiving parenteral nutrition, stemming from several developmental factors. These include decreased endogenous insulin production, peripheral insulin resistance, and increased hepatic glucose output. Additionally, preterm infants have immature liver enzyme systems and abnormal insulin receptor number and function, all contributing to impaired glucose homeostasis. When managing hyperglycemia in these patients, the initial approach involves reducing the glucose infusion rate. However, it's critical to maintain a minimum GIR of 4 milligrams per kilogram per minute to prevent hypoglycemia and ensure adequate caloric intake for growth. This represents the lower threshold for safe glucose administration in neonates. For persistent hyperglycemia, despite appropriate GIR reduction, insulin therapy should be considered at doses of 0.05 to 0.1 units per kilogram per hour. It's important to monitor closely for rebound hypoglycemia, as preterm infants are particularly susceptible to rapid glucose fluctuations. The goal is to achieve glucose control while maintaining adequate nutritional support for optimal growth and development. Intravenous lipid emulsions serve three critical functions: providing concentrated energy, preventing essential fatty acid deficiency, and supporting fat-soluble vitamin absorption. Term infants require 2 to 4 grams per kilogram daily, while preterm infants need 2 to 3.5 grams per kilogram daily to meet their energy and growth demands. The minimum dose of 0.5 grams per kilogram daily prevents essential fatty acid deficiency, which can develop within 72 hours of inadequate lipid provision. Administration follows a careful escalation. Begin with 0.5 to 1 gram per kilogram on day 1, then advance by 0.5 grams per kilogram every 1 to 2 days until reaching the target dose. Maximum daily dose should not exceed 3 grams per kilogram, and the infusion rate must remain below 0.15 grams per kilogram per hour to prevent lipid overload syndrome. The preferred 20% emulsion provides 2 kilocalories per milliliter, making dosing calculations straightforward. Triglyceride monitoring becomes essential when doses exceed 2 grams per kilogram daily. Levels should remain below 250 milligrams per deciliter. When triglycerides become elevated, reduce the dose by 0.5 to 1 gram per kilogram daily, rather than stopping lipids entirely, as complete cessation risks essential fatty acid deficiency. Lipid emulsion selection in neonatal parenteral nutrition involves consideration of fatty acid composition and its impact on essential fatty acid status in preterm populations. SMOF lipid, a multi-component emulsion containing soybean oil, medium-chain triglycerides, olive oil, and fish oil, was developed to provide potential advantages, including reduced inflammatory response and improved hepatic function compared to conventional soybean oil-based emulsions. However, significant differences exist in essential fatty acid content between lipid formulations. Intralipid contains approximately 53% linoleic acid, while SMOF lipid provides only 19.5% linoleic acid content. This reduction in essential fatty acid concentration presents clinical challenges for preterm infants who possess minimal endogenous fatty acid stores at birth and require adequate linoleic acid for normal growth and development. Clinical evidence indicates that SMOF lipid administration at doses below 3.0 grams per kilogram per day may result in essential fatty acid deficiency in preterm infants within several days of initiation. This finding necessitates careful consideration of lipid dosing strategies when utilizing lower essential fatty acid content emulsions to prevent biochemical deficiency states while maintaining the potential benefits of multi-component lipid formulations. Mineral requirements in parenteral nutrition follow evidence-based guidelines that reflect the massive accretion needs of rapidly growing preterm infants. Calcium requirements range from 60 to 90 milligrams per kilogram daily, equivalent to 2 to 4 milliequivalents per kilogram, providing the substrate for bone mineralization that normally occurs during the third trimester, when 80% of fetal calcium accumulation takes place. Phosphorus provision must parallel calcium at 45 to 60 milligrams per kilogram daily, equal to 1 to 2 millimoles per kilogram, to support energy metabolism and bone formation. The calcium to phosphorus ratio proves critical for optimal bone mineralization. Maintaining a milligram to milligram ratio of 1.3 to 1.7 to 1, or a molar ratio of 1 to 1, ensures appropriate mineral deposition in developing bone matrix. Magnesium requirements of 4 to 7 milligrams per kilogram daily, equivalent to 0.3 to 0.6 milliequivalents per kilogram, support enzymatic functions and mineral metabolism, though initial provision may need adjustment if mothers received magnesium therapy for preterm labor. Vitamin D provision at 120 to 160 international units daily promotes calcium absorption and bone metabolism, though higher doses may benefit preterm infants with osteopenia risk. Trace element supplementation focuses on zinc and selenium as early additions. Zinc at 400 micrograms per kilogram daily for preterm infants and 250 micrograms per kilogram for term infants prevents deficiency in this critical cofactor for over 300 enzymes, while selenium at 2 to 3 micrograms per kilogram daily supports antioxidant defense and thyroid function. The clinical challenge involves early, aggressive nutrition, potentially precipitating profound hypophosphatemia, as rapidly dividing cells consume phosphorus faster than replacement occurs, creating a refeeding syndrome scenario where cellular metabolism outpaces the ability to provide adequate substrate. Trace element requirements reflect the microscopic needs that determine macroscopic outcomes. Zinc requirements differ significantly by gestational age. Premature infants need 400 micrograms per kilogram daily, compared to 250 micrograms per kilogram for term infants. This difference matters because zinc serves as a cofactor for over 300 enzymes essential for growth, cell differentiation, and nutrient metabolism. Zinc accumulation occurs primarily during the third trimester, leaving premature infants at high risk for deficiency. Clinical signs include poor growth, periorificial dermatitis, glossitis, and increased infection risk. An often overlooked population at risk includes infants with chronic lung disease receiving diuretics. These medications increase urinary zinc losses, contributing to growth failure. Copper requirements remain consistent at 20 micrograms per kilogram regardless of gestational age. Copper deficiency presents as hypochromic anemia that mimics iron deficiency, revealing copper's role in iron transport from hepatic stores. The outdated practice of reducing copper with cholestasis has been abandoned due to multiple reports of subsequent copper deficiency. Selenium needs are 2 to 3 micrograms per kilogram daily for its role in antioxidant defense and thyroid function. Both chromium and manganese exist as contaminants in parenteral nutrition solutions, typically eliminating the need for additional supplementation. Additional parenteral nutrition components address specific metabolic needs that become critical during prolonged intravenous feeding. L-carnitine represents a nitrogen-containing compound essential for transferring fatty acids into cellular mitochondria where beta-oxidation occurs for energy production. Carnitine deficiency can develop within 2 weeks after birth if not provided in the diet, since breast milk serves as an excellent natural source and formulas are routinely supplemented. But parenteral nutrition lacks this component. Despite claims about triglyceride reduction, no evidence supports L-carnitine's impact on serum triglyceride levels, making its primary indication the prevention of deficiency rather than lipid management. Parenteral nutrition should include L-carnitine supplementation at 8 to 10 milligrams per kilogram daily for infants requiring extended intravenous nutrition. Magnesium supplementation requires careful consideration of maternal therapy. Hypermagnesemia may occur in premature infants whose mothers received magnesium sulfate for seizure prophylaxis or tocolysis, necessitating initial withholding of magnesium from parenteral nutrition until serum levels normalize to prevent toxicity. Once maternal effects dissipate, magnesium supplementation becomes essential for enzymatic functions and mineral metabolism. Standard pediatric vitamin preparations added to parenteral nutrition solutions contain adequate amounts of all essential vitamins to prevent deficiency diseases. Though these synthetic preparations may not provide the same bioavailability or protective effects as vitamins obtained through enteral nutrition, emphasizing the importance of transitioning to enteral feeds as quickly as safely possible. Parenteral nutrition complications represent serious threats that increase with duration of therapy, making transition to enteral nutrition a clinical imperative. Hepatic dysfunction and cholestasis develop when direct bilirubin levels exceed 2 milligrams per deciliter. often progressing to severe liver disease if parenteral nutrition continues without modification. Treatment involves switching from standard soybean oil-based lipids to specialized formulations. SMOF lipid, with its blend of soybean, medium-chain triglycerides, olive, and fish oils, or Omega-Ven with 100% fish oil composition, both designed to reduce hepatotoxicity. Line-related infections pose constant threats, including bacterial bloodstream infections and fungal sepsis, with lipid emulsions creating particular risk for fungal growth due to their rich nutrient content. Metabolic complications span multiple organ systems. Glucose instability ranging from hypoglycemia to hyperglycemia challenges glucose homeostasis. Electrolyte imbalances including hypernatremia, hyponatremia, hyperkalemia, and hypokalemia require constant monitoring and adjustment. Hyperammonemia can develop from excessive amino acid administration or hepatic dysfunction, and metabolic acidosis often results from amino acid metabolism or L-cysteine supplementation. Anemia becomes inevitable because parenteral nutrition contains no iron supplementation, leading to progressive iron deficiency as blood draws deplete iron stores without replacement. Metabolic bone disease develops when calcium and phosphorus provision fails to meet the enormous demands of rapid bone formation, while catheter-related complications, including thrombosis, extravasation, and mechanical failures, create additional risks. These complications underscore why parenteral nutrition, despite being life-saving, represents a therapeutic bridge rather than a destination. Every effort must focus on achieving enteral nutrition as quickly and safely as possible. Enteral nutrition requirements exceed parenteral needs due to the metabolic costs of digestion and absorption. Term infants require 105 to 115 kilocalories per kilogram daily, while preterm infants need significantly more, at 110 to 135 kilocalories per kilogram daily to support their rapid growth rates. Energy distribution should target 40 to 50% from carbohydrates, providing 8 to 12 grams per kilogram daily, 30 to 55% from fats, delivering 3 to 4 grams per kilogram daily, and 10 to 16% from protein. Protein requirements differ dramatically by gestational age. Term infants need only 2 to 2.5 grams per kilogram daily, while preterm infants require 3.5 to 4.5 grams per kilogram daily, nearly double the term requirement. This increased protein need reflects the preterm infant's rapid tissue synthesis and organ development occurring outside the protective uterine environment. Enteral nutrition provides benefits impossible to achieve parenterally. Gut hormone stimulation promotes motility development, enzyme maturation enhances digestive capacity, reduced intestinal permeability prevents bacterial translocation, and decreased cholestasis risk protects liver function. The mandate to begin enteral stimulation immediately stems from the biological imperative that gut development cannot occur without luminal nutrition, regardless of volume. Protein digestion begins with mechanical breakdown in specific anatomical locations, each contributing unique enzymatic functions. The stomach produces pepsin and renin, which initiate protein hydrolysis into larger peptide fragments, but cannot complete the digestive process. The small bowel serves as the primary site of protein digestion, where pancreatic enzymes including trypsin, chymotrypsin, elastase, enterokinase, and carboxypeptidase systematically cleave proteins into di- and tripeptides small enough for intestinal absorption. Only these smallest peptide units can cross the intestinal barrier into systemic circulation. Protein requirements vary dramatically by developmental stage. Term infants require only 2.2 grams per kilogram daily, reflecting their slower growth velocity, while preterm infants need substantially more at 3.5 to 4.5 grams per kilogram daily, potentially double the term requirement. The smallest preterm infants may require up to 4 grams per kilogram daily to support their explosive tissue synthesis. Whey proteins offer significant advantages over casein. Higher cysteine content supports antioxidant production, lower methionine reduces metabolic stress, enhanced gastric emptying improves feeding tolerance, easier digestibility reduces energy expenditure, and immune-supporting proteins protect against infection. For preterm infants, essential amino acids expand beyond the normal 8 to include cysteine, taurine, arginine, and tyrosine due to immature enzymatic pathways that cannot synthesize these amino acids at adequate rates. Fat digestion involves 3 critical enzymatic processes. Lingual lipase begins hydrolysis in the mouth, pancreatic lipase continues breakdown in the duodenum, and bile salts facilitate emulsification throughout the small intestine. Body fat stores accumulate not only through dietary fat absorption, but also through lipogenesis, the conversion of excess glucose into fatty acids for storage. Neonates depend heavily on intragastric lipases for fatty acid digestion, demonstrating superior absorption of fatty acids with decreased chain length and unsaturated chemical structures. The most abundant fatty acids in human nutrition include stearic acid, oleic acid, and palmitic acid, though these longer-chain saturated fats present absorption challenges for immature digestive systems. Essential fatty acids, linoleic acid, and alpha-linolenic acid cannot be synthesized endogenously and must be provided through nutrition. Short and medium-chain triglycerides offer optimal absorption characteristics for preterm infants because they require minimal pancreatic lipase and bile salt activity, absorb rapidly through the portal circulation, and bypass the complex chylomicron formation process. However, medium-chain triglycerides cannot provide essential fatty acids, making them insufficient as sole fat sources. Long-chain polyunsaturated fatty acids, specifically docosahexaenoic acid and arachidonic acid, prove critical for retinol development and brain maturation, with accumulation occurring primarily during the 3rd trimester and early postnatal months, when physiologic requirements reach their peak. Lactose serves as the predominant carbohydrate in breast milk and most standard formulas, but preterm formulas strategically replace portions of lactose with corn syrup and short-chain glucose polymers to accommodate developmental limitations. Lactase enzyme activity remains significantly decreased in premature infants, not reaching full functionality until term gestation, explaining why preterm infants often experience lactose intolerance with standard formulas. Fortunately, sucrase isomaltase enzyme production remains normal in preterm infants, allowing them to digest glucose polymers and corn syrup effectively when combined with reduced lactose concentrations. Despite this accommodation, lactose provides irreplaceable benefits: enhanced calcium and magnesium absorption through improved mineral solubility, and promotion of beneficial lactobacilli growth in the intestinal microbiome. Complete lactose elimination would sacrifice these advantages, making the partial replacement strategy optimal for preterm nutrition. Carbohydrate digestion relies on multiple enzymatic systems working in sequence. Salivary amylase initiates starch breakdown in the mouth, pancreatic amylase continues the process in the duodenum, intestinal amylase completes complex carbohydrate hydrolysis, and brush border disaccharidases including lactase, sucrase isomaltase, and maltase cleave double sugars into absorbable monosaccharides. This enzymatic cascade must function efficiently to provide the glucose essential for brain metabolism and cellular energy production in rapidly growing preterm infants. Oral feeding readiness requires 3 developmental milestones: gestational age of at least 34 weeks when neurologic maturation supports coordination, demonstration of coordinated suck-swallow-breathe patterns during assessment, and stable respiratory status that won't be compromised by feeding efforts. Gavage feeding techniques offer multiple approaches based on clinical needs. Orogastric versus nasogastric tube placement affects comfort and respiratory function, while continuous versus bolus delivery methods influence feeding tolerance and gastric development. Tube sizing follows weight-based guidelines. Infants below 1,000 grams require 5 French tubes to minimize airway compromise, while larger infants above 1,000 grams accommodate 6 to 8 French tubes for improved flow rates and reduced occlusion risk. Post-pyloric feeding becomes necessary for specific clinical indications, including aspiration risk from gastroesophageal reflux, severe reflux unresponsive to positioning and medications, and chronic lung disease where aspiration could prove catastrophic. Post-pyloric feeds must use continuous infusion rather than bolus delivery to prevent intestinal distension and feeding intolerance. Trophic feeding, defined as volumes of 24 milliliters per kilogram daily or less, should begin on day 1 to 2 of life, with the primary purpose of intestinal maturation rather than nutritional provision. Advancement rates require careful titration. Standard preterm infants can typically tolerate increases of 20 to 30 milliliters per kilogram daily, while extremely low birth weight infants need more conservative progression at 15 to 25 milliliters per kilogram daily to prevent feeding intolerance. Evidence-based standardized feeding protocols consistently demonstrate improved outcomes, including faster achievement of full enteral feeds, reduced parenteral nutrition duration, enhanced growth velocity, and most importantly, significant reduction in necrotizing enterocolitis incidence. Feeding tolerance assessment requires systematic evaluation of multiple clinical parameters to distinguish normal adaptation from pathologic complications that demand intervention. Warning signs requiring immediate evaluation include gastric residuals exceeding 30% of the previous feeding volume, which suggests delayed gastric emptying or intestinal obstruction that could progress to more serious complications. Abdominal distension with visible bowel loops indicates intestinal dysfunction that may herald necrotizing enterocolitis or other surgical emergencies requiring immediate assessment. Bloody stools represent a particularly ominous sign, suggesting mucosal injury, inflammation, or ischemia that could indicate necrotizing enterocolitis, milk protein allergy, or other serious pathology. Bilious emesis suggests intestinal obstruction or severe motility dysfunction that requires immediate evaluation and likely feeding cessation until surgical causes are ruled out. Apnea and bradycardia occurring during feeds may indicate gastroesophageal reflux with aspiration risk, feeding intolerance due to increased metabolic demands, or cardiac compromise from vagal stimulation during feeding. However, the critical clinical pearl involves understanding that gastric residuals alone, without accompanying signs, should not automatically trigger feeding cessation. Research consistently demonstrates that residuals without other symptoms often represent normal gastric function variation rather than pathologic feeding intolerance. The decision to withhold feeds should be based on comprehensive clinical assessment rather than isolated residual volumes, as unnecessary feeding delays can prolong parenteral nutrition dependence and delay achievement of full enteral nutrition. Successful feeding advancement requires balancing appropriate caution against overly aggressive suspension of feeds for isolated findings that may not represent true intolerance. Human milk composition changes dynamically to meet infant developmental needs. Colostrum produced in the first few days contains approximately 2 grams per deciliter of protein, along with concentrated immunoglobulins, but lower fat and carbohydrate concentrations. Mature milk stabilizes at about 1 gram per deciliter protein and provides 20 kilocalories per ounce, perfectly calibrated for term infant nutrition. Preterm mothers produce milk uniquely adapted to their infant's needs. During the first 2 to 4 weeks after delivery, higher protein concentrations, elevated sodium and chloride levels, and enhanced immunologic factors compared to term milk. The whey to casein protein ratio shifts significantly during lactation. Colostrum begins at 80 to 20, favoring easily digestible whey proteins, while mature milk settles at 55-45. Compare this to preterm formulas designed at 60-40 to mimic early milk benefits, while standard cow's milk provides only 20 to 80, heavily weighted toward harder-to-digest casein proteins. Human milk oligosaccharides represent the third largest component, after lactose and fat, reaching concentrations of 20 grams per liter in colostrum and 10 to 15 grams per liter in mature milk. These complex carbohydrates remain undigested by the infant, but provide essential nutrition for beneficial gut bacteria while blocking pathogen adherence to intestinal walls. Human milk demonstrates significant protective effects against necrotizing enterocolitis in preterm infant populations, with studies indicating approximately 50% reduction in NEC incidence compared to formula-fed infants. This substantial risk reduction is attributed to multiple bioactive components with distinct protective mechanisms. Human milk oligosaccharides serve as prebiotic substrates and function as competitive inhibitors for pathogenic bacterial adhesion to intestinal epithelium. These complex carbohydrates bind to bacterial adhesins, preventing colonization of potentially harmful microorganisms and promoting beneficial microbiota development. Additionally, human milk contains numerous growth factors, including epidermal growth factor and transforming growth factor beta, which stimulate intestinal maturation, promote angiogenesis, and enhance mucosal barrier function. Lactoferrin, an iron-binding glycoprotein abundant in human milk, demonstrates antimicrobial properties through iron sequestration from pathogenic bacteria while facilitating iron transport to develop in tissues. This protein also exhibits direct bactericidal effects and modulates immune responses in the developing gastrointestinal tract. The synergistic effects of these bioactive components contribute to enhanced intestinal development, improved immune function, and reduced inflammatory responses in preterm infants. Clinical evidence consistently supports human milk as the optimal nutritional intervention for preventing NEC and promoting gastrointestinal maturation in this vulnerable population. Human milk storage and handling protocols directly impact the preservation of bioactive components that provide irreplaceable nutritional and immunological benefits, making proper technique essential for maintaining milk quality and infant safety. Collection guidelines establish the foundation for safe milk handling. Hand hygiene prior to expression prevents bacterial contamination that could cause infant illness or spoilage during storage, while cleaning collection kits with hot, soapy water removes protein and fat residues that harbor pathogenic bacteria. Container selection affects both safety and nutrient preservation. Hard plastic or glass containers maintain structural integrity and prevent chemical leaching, while soft plastic storage bags risk puncture, contamination, and potential transfer of plasticizers into the milk. Proper labeling with mother's name, collection date, and exact time ensures accurate identification, prevents mix-ups between mothers, and enables first-in, first-out rotation that maintains optimal milk quality. Storage duration guidelines reflect the temperature-dependent growth patterns of bacteria and degradation of bioactive components. Room temperature storage allows only 4 hours before bacterial multiplication reaches dangerous levels and immunoglobulin activity begins declining. Refrigeration at 4 degrees Celsius dramatically slows bacterial growth and preserves most bioactive factors for 96 hours, making this the optimal method for short-term storage and transport between home and hospital. Freezer compartment storage at standard freezer temperatures maintains milk safety and most nutritional components for 3 to 6 months, though some immunoglobulin activity decreases over time. Deep freezer storage at -20 degrees Celsius provides maximum preservation, maintaining milk quality for 6 to 12 months with minimal degradation of proteins and fats, though frozen storage does eliminate live cells and reduces some enzyme activity. Critical handling procedures prevent nutrient loss and contamination. Thawing with tepid water preserves heat-sensitive immunoglobulins and growth factors while ensuring even temperature distribution, whereas microwave heating creates dangerous hotspots and destroys protective proteins. Using thawed milk within 24 hours prevents bacterial overgrowth in previously frozen milk, and never refreezing ensures that repeated freeze-thaw cycles don't damage cellular components or create food safety risks. Human milk fortification addresses the nutritional gap between the composition of unmodified human milk and the elevated requirements of preterm infants. While human milk provides optimal nutrition for term infants, it contains insufficient protein, minerals, and calories to support the accelerated growth rates required for preterm infant development. Preterm infants, particularly those born before 32 weeks gestation, require protein concentrations of 3.5 to 4 grams per kilogram per day and caloric densities of 100 to 120 kcals per kilogram per day, significantly exceeding the concentrations provided by unmodified human milk. These requirements approach the upper limits of renal solute handling capacity and osmotic tolerance in this population. Fortification protocols modify multiple physicochemical properties of human milk beyond nutritional content, including osmolality, pH, and bacterial growth characteristics. These alterations require careful monitoring to prevent complications such as feeding intolerance or increased infection risk. The timing of fortification initiation is clinically significant, as premature introduction may exceed renal handling capacity, while delayed initiation may result in suboptimal protein accretion during critical growth periods. Optimal fortification strategies balance the preservation of human milk's immunological and developmental benefits while meeting the enhanced nutritional requirements necessary for appropriate growth velocity and neurodevelopmental outcomes in preterm populations. Human milk fortifier selection involves understanding the distinct characteristics and protein content of available products. Bovine-based options include multiple formulations with varying protein concentrations. Powder fortifiers from Abbott and Mead Johnson provide standard protein supplementation, while concentrated liquid fortifiers from Abbott offer sterile preparation advantages. The more specialized products deliver significantly higher protein concentrations. Liquid human milk fortifier high protein from Mead Johnson, acidified liquid from Mead Johnson, and hydrolyzed protein concentrated liquid from Abbott all achieve protein levels that can meet the 4 grams per kilogram daily requirement when used enterally. Abbott's liquid protein fortifier can be added to other fortifiers to boost protein content when needed. A critical limitation exists with the first 2 product categories. Powder and standard concentrated liquid fortifiers cannot achieve 4 grams per kilogram protein daily through enteral routes alone, potentially compromising growth in the smallest infants. Human milk-based fortifiers from Prolacta offer alternatives derived from donor human milk. Prolact plus 4, plus 6, plus 8, and plus 10 provide increasing caloric densities, while Prolact cream adds concentrated calories without additional protein. The primary advantage of liquid products involves sterility. They eliminate the bacterial contamination risk associated with powder preparation, though they typically cost more and require different storage considerations compared to powder formulations. Donor human milk provides essential nutrition for specific high-risk populations when maternal milk remains unavailable. Clinical indications focus on very low birth weight infants below 1,500 grams and those born before 32 weeks gestation, populations that benefit most from human milk's protective properties. The processing required for donor milk safety significantly impacts nutritional quality. Holder pasteurization at 62.5 degrees Celsius for 30 minutes eliminates pathogens but also destroys heat-sensitive bioactive components, while multiple freeze-thaw cycles during collection, processing, and distribution further reduce energy and protein content compared to fresh maternal milk. Specific losses include complete elimination of beneficial lipase enzymes that aid fat digestion, destruction of the protective microbiome that supports immune development, reduced concentrations of growth factors like insulin-like growth factor, and decreased immunoglobulin levels that provide passive immunity. The bridge milk concept represents an emerging practice of providing donor milk from birth until maternal lactogenesis occurs, typically within the first 5 days postpartum. This approach proves particularly valuable for moderately preterm infants, like 34-weekers, whose mothers may experience delayed milk production due to complications like hypertension or surgical delivery. Despite these processing limitations, donor human milk consistently demonstrates superior outcomes compared to formula feeding, including reduced necrotizing enterocolitis incidence, improved feeding tolerance, and maintenance of some immunological properties, making it the preferred second choice when maternal milk cannot be obtained. Establishing adequate milk supply requires immediate and sustained maternal support. Following evidence-based protocols, mothers should begin pumping within 6 hours of delivery to stimulate prolactin and oxytocin release, mimicking the natural feeding patterns that would occur with term infants. Frequency proves more important than duration. Mothers need to pump at least 8 times daily initially, including overnight sessions, to establish robust milk production. The target goal of 600 to 750 milliliters daily by 10 to 14 days postpartum ensures adequate supply for growing preterm infants while building freezer reserves for potential complications. Contraindications to breastfeeding remain remarkably limited in developed countries. Infant galactosemia represents the only absolute contraindication. These infants cannot metabolize galactose from lactose, making any breast milk exposure potentially toxic. Maternal factors include active human immunodeficiency virus infection, where transmission risk outweighs benefits in resource-rich environments. Active, untreated tuberculosis, where airborne transmission poses immediate danger. Herpes simplex virus lesions specifically on the breast tissue, and certain maternal medications, including cytotoxic chemotherapy agents and radioactive compounds. Drugs of abuse, including cocaine, heroin, and methamphetamines, also contraindicate breastfeeding due to infant exposure risks. The critical clinical pearl involves medication compatibility. The vast majority of maternal medications are actually compatible with breastfeeding, making unnecessary cessation of nursing a common but preventable tragedy that deprives infants of irreplaceable nutritional and immunologic benefits. Formula selection requires understanding fundamental differences between standard and preterm formulations designed for distinct nutritional needs. Standard cow's milk formulas provide 20 kilocalories per ounce with a casein-predominant protein ratio of 20 to 80 weight to casein, reflecting the natural composition of cow's milk rather than human milk's whey-predominant profile. All fat calories derive from long-chain triglycerides sourced from vegetable oils, which require mature digestive enzyme systems for optimal absorption. Iron fortification offers 2 options: 12 milligrams per liter in iron-fortified formulas recommended for most infants, or 1.5 milligrams per liter in low-iron formulas reserved for specific medical indications. Preterm formulas address the unique challenges of immature physiology through multiple modifications. Increased caloric density to 24 kilocalories per ounce reduces volume requirements while meeting energy needs. Elevated protein content, ranging from 3.6 to 4.2 grams per 100 kilocalories, supports rapid tissue synthesis. 50% of fat calories provided as medium-chain triglycerides improve absorption in the setting of limited pancreatic lipase. Enhanced mineral content, particularly calcium and phosphorus, promotes bone mineralization. Increased vitamin concentrations prevent deficiency states. Partial hydrolysate protein reduces allergenic potential while improving digestibility, and partial medium-chain triglyceride content optimizes fat absorption without completely eliminating essential long-chain fatty acids. These modifications transform formula from basic nutrition into therapeutic intervention designed specifically for the metabolic demands and physiologic limitations of premature development. Specialized formulas address specific medical conditions that standard cow's milk formulas cannot accommodate safely or effectively. Soy-based formulas have severely limited indications, according to American Academy of Pediatrics guidelines, updated in 2008. The few appropriate uses include galactosemia, where lactose must be completely eliminated, hereditary lactase deficiency, which is extremely rare, and families preferring vegetarian nutrition sources. Importantly, soy formulas are explicitly not recommended for preterm infants due to inferior protein bioavailability and significantly increased risk for metabolic bone disease development. High cross-reactivity exists between cow's milk and soy proteins, with 10 to 14% of infants allergic to cow's milk also demonstrating soy protein sensitivity. Protein hydrolysate formulas contain extensively hydrolyzed proteins that reduce allergenic potential while maintaining nutritional adequacy. Carbohydrate sources include corn syrup solids and various starches, while fat composition varies between all long-chain triglycerides or blended medium-chain and long-chain triglyceride formulations. Indications include confirmed cow's milk protein allergy, soy protein allergy, gastroesophageal reflux disease, gastrointestinal or liver diseases requiring easier digestion, and prevention of atopic disease when exclusive breastfeeding for 4 to 6 months proves impossible. Elemental formulas represent the most specialized option with free amino acid-based protein sources for infants with severe protein hypersensitivity or malabsorption syndromes. These formulas prove extremely expensive and difficult for families to obtain, though programs like Women, Infants, and Children may provide coverage with appropriate medical documentation. Preterm discharge formulas bridge the gap between hospital and home nutrition, providing 22 kilocalories per ounce with enhanced protein, vitamin, and mineral content recommended until 9 months corrected age for improved linear growth, weight gain, and bone mineral content. Formula selection must match specific clinical conditions to optimize therapeutic outcomes while avoiding complications. Galactosemia mandates complete lactose elimination, making soy-based formulas the standard choice since they provide lactose-free nutrition without requiring expensive elemental alternatives. Cow's milk protein allergy requires escalating interventions based on severity, extensively hydrolyzed formulas for moderate reactions, or elemental amino acid-based formulas for severe hypersensitivity that fails to respond to hydrolyzed proteins. Chylothorax creates unique nutritional challenges, requiring formulas with 84% medium-chain triglycerides and only 15% long-chain triglycerides, since long-chain fats enter the lymphatic circulation and would increase chyle output, potentially worsening the effusion. Bronchopulmonary dysplasia and chronic lung disease demand high-energy, nutrient-dense formulations that provide maximum calories in minimal volumes due to fluid restriction requirements. These infants cannot tolerate the large volumes needed with standard 20 kilocalorie per ounce formulas. Short bowel syndrome benefits from semi-elemental formulas with predigested nutrients that reduce the absorptive burden on remaining intestinal surface area, though these infants often require long-term parenteral nutrition supplementation. Hepatic dysfunction necessitates formulas with reduced long-chain triglycerides at 45%, and increased medium-chain triglycerides at 55%, since medium-chain fats bypass the portal circulation and reduce hepatic metabolic demands. Post-necrotizing enterocolitis management typically employs preterm formulas or semi-elemental alternatives depending on the extent of intestinal resection and residual absorptive capacity, with advancement guided by feeding tolerance and growth response. Glucose management requires precise understanding of normal ranges and risk stratification to prevent neurologic catastrophe. Normal glucose levels range from 40 to 125 milligrams per deciliter, with hypoglycemia definitions based on symptom presence and severity. Symptomatic hypoglycemia below 40 milligrams per deciliter, accompanied by clinical manifestations, demands immediate intervention, while asymptomatic hypoglycemia below 45 milligrams per deciliter, without symptoms, allows more measured response with close monitoring. Clinical symptoms progress from subtle to life-threatening. Early signs include jitteriness, lethargy, and poor feeding that may be easily dismissed as normal newborn behavior, while severe hypoglycemia manifests as apnea, bradycardia, seizures, and potentially irreversible coma with permanent neurologic sequelae. Risk factor identification guides prevention strategies. Prematurity increases susceptibility due to limited glycogen stores and immature gluconeogenesis pathways. Small for gestational age infants have reduced energy reserves from intrauterine growth restriction. Large for gestational age infants may experience hyperinsulinemia and rapid glucose consumption. Infants of diabetic mothers develop insulin excess from maternal hyperglycemia exposure. Perinatal stress, including birth asphyxia or hypothermia, accelerates glucose utilization, and sepsis dramatically increases metabolic demands while impairing glucose production. Understanding these risk factors allows anticipatory management with early glucose monitoring, prompt feeding initiation, and immediate intervention when hypoglycemia develops, potentially preventing the devastating neurodevelopmental consequences that can result from inadequate cerebral glucose supply during critical periods of brain development. Glucose management protocols must differentiate between asymptomatic and symptomatic presentations to guide appropriate interventions. Asymptomatic hypoglycemia, defined as glucose levels below 45 mg per deciliter without clinical signs, can initially be managed with early enteral feeding when the infant demonstrates feeding readiness. If hypoglycemia persists despite feeds, or the infant cannot take enteral nutrition, intravenous dextrose becomes necessary. Symptomatic hypoglycemia below 40 mg per deciliter with clinical manifestations like jitteriness, lethargy, or poor feeding demands, immediate intervention with an intravenous dextrose bolus, 2 ml per kilogram of 10% dextrose solution administered promptly. This bolus must be followed immediately by a continuous glucose infusion to prevent rebound hypoglycemia. Maintenance glucose infusion rates vary by gestational age. Term infants typically require 4 to 5 mg per kilogram per minute, while preterm infants need higher rates of 6 to 8 mg per kilogram per minute due to increased metabolic demands and limited glycogen stores. The critical warning involves overcorrection. Aggressive glucose administration can trigger hyperinsulinemia, leading to profound rebound hypoglycemia that may be more dangerous than the original episode. Careful titration prevents these complications while maintaining adequate cerebral glucose delivery. Hyperglycemia management requires systematic understanding of causative factors and graded interventions to restore glucose homeostasis without creating dangerous rebound hypoglycemia. Hyperglycemia definitions vary between institutions, but typically use thresholds of 125 to 150 milligrams per deciliter, recognizing that extremely low birth weight infants may tolerate higher glucose levels than larger preterm infants due to their unique physiology. Common etiologies reflect the complex metabolic challenges of prematurity, excessive glucose infusion rates that exceed the infant's limited oxidative capacity create substrate overload. Physiologic stress from sepsis or surgical procedures triggers massive counter-regulatory hormone release, including cortisol and catecholamines that promote gluconeogenesis. Medications, particularly corticosteroids, directly stimulate glucose production while vasopressors increase insulin resistance. And primary insulin resistance frequently develops in extremely low birth weight infants whose immature pancreatic beta cells cannot produce adequate insulin to meet metabolic demands. Management follows a careful stepwise approach, beginning with glucose infusion rate reduction, though this must never drop below the critical threshold of 4 milligrams per kilogram per minute required for essential brain glucose utilization, even in the face of severe hyperglycemia. When hyperglycemia persists despite appropriate glucose infusion rate adjustments, continuous insulin therapy becomes necessary, using carefully titrated infusion rates of 0.05 to 0.1 units per kilogram per hour, with frequent glucose monitoring to prevent overcorrection. Monitoring for hypoglycemia during insulin treatment requires heightened vigilance because rapid glucose decline can prove more dangerous than the original hyperglycemia. The critical warning involves avoiding rapid glucose fluctuations in either direction. Dramatic swings between hyperglycemia and hypoglycemia significantly increase the risk of intraventricular hemorrhage, particularly in extremely premature infants whose fragile cerebral vasculature cannot tolerate the pressure changes and osmotic shifts associated with glucose instability. Bronchopulmonary dysplasia creates a nutritional paradox requiring increased calories within restricted fluid volumes that challenges traditional feeding approaches. These infants demonstrate caloric needs 20 to 40% above normal requirements due to increased work of breathing, chronic inflammation, and ongoing lung repair processes that dramatically elevate metabolic demands. Simultaneously, fluid restriction to 100 to 130 milliliters per kilogram daily becomes essential to prevent pulmonary edema and worsening respiratory function. This combination necessitates higher caloric density formulations of 26 to 30 kilocalories per ounce to meet energy needs, without volume overload. Feeding strategies must accommodate respiratory compromise. Smaller, more frequent feeds reduce diaphragmatic compression and allow adequate ventilation between feeding episodes. Continuous feeds may improve tolerance by minimizing gastric distension that could impair respiratory mechanics. And post-pyloric feeding consideration becomes important when gastroesophageal reflux poses aspiration risks that could devastate already compromised lungs. Monitoring requires careful attention to multiple parameters. Fluid status assessment through daily weights and intake-output calculations ensures appropriate balance between adequate nutrition and volume restriction. Growth parameter tracking, including weight gain and linear growth, helps optimize caloric provision. And respiratory status evaluation during feeds identifies feeding-related distress that might require technique modifications. The goal involves achieving adequate nutrition for growth and lung development while respecting the physiologic limitations imposed by chronic lung disease, often requiring months of careful nutritional management before weaning from specialized feeding approaches becomes possible. Short bowel syndrome presents complex nutritional challenges stemming from dramatically reduced intestinal absorptive capacity following congenital anomalies or extensive surgical resection. The definition centers on insufficient functional bowel length to maintain nutritional needs through enteral absorption alone. Critical anatomic thresholds determine viability. Infants require a minimum of 25 centimeters of small bowel when the ileocecal valve remains intact, or 40 centimeters without the ileocecal valve to achieve eventual enteral autonomy. Nutritional challenges compound rapidly. Reduced absorptive surface area creates malabsorption of all macronutrients and most micronutrients. Vitamin and mineral deficiencies develop quickly due to specific absorption sites being resected. High risk for bacterial overgrowth occurs when normal intestinal anatomy and motility are disrupted, and fluid and electrolyte losses can become massive when large portions of colon are absent. Management requires comprehensive, long-term planning. Specialized formulas with lower osmolality reduce the osmotic load that could worsen diarrhea and fluid losses. Medium-chain triglyceride supplementation improves fat absorption since these fats bypass lymphatic circulation and absorb directly into portal blood. Continuous feeds delivered at slow rates maximize contact time between nutrients and remaining absorptive surface while minimizing osmotic effects. Long-term parenteral nutrition support becomes essential during the months or years required for intestinal adaptation, and gradual enteral nutrition advancement follows careful protocols that respect the remaining bowel's limited capacity while encouraging adaptation through luminal stimulation. Success depends on the delicate balance between providing adequate nutrition for growth and development while allowing time for whatever intestinal adaptation may be possible. Osteopenia of prematurity reflects the devastating bone demineralization that occurs when premature birth interrupts the critical third trimester period of skeletal development. Biochemical markers provide diagnostic guidance. Elevated alkaline phosphatase levels above 800 international units per liter serve as the primary screening tool for osteopenia development, while serum phosphorus levels below 4 milligrams per deciliter suggest inadequate bone mineralization and phosphorus deficiency. These laboratory values represent the best available biomarkers, though they cannot definitively diagnose osteopenia without clinical correlation. Multiple risk factors contribute to bone demineralization. Normal bone mineralization occurs predominantly during the last trimester when 80% of fetal calcium accretion takes place. Long-term parenteral nutrition with suboptimal calcium and phosphorus provision fails to meet the massive mineral requirements of rapid bone formation. Diuretic medications increase urinary calcium and phosphorus losses. Seizure medications can interfere with vitamin D metabolism and bone formation, and delayed enteral feeding prevents the provision of adequate minerals through the most efficient absorption route. Monitoring protocols focus on laboratory surveillance. Alkaline phosphatase and serum calcium and phosphorus levels require regular assessment, with particular attention to hypophosphatemia, since serum phosphorus below 4 milligrams per deciliter associates strongly with osteopenia development. Prevention strategies emphasize early nutritional intervention. Immediate initiation of enteral feeds provides optimal mineral absorption. Timely fortification ensures adequate calcium and phosphorus provision when feeding volumes reach appropriate levels. And maximizing calcium and phosphorus concentrations in parenteral nutrition during the transition period supports bone formation when enteral nutrition remains limited. Routine supplementation protocols address specific deficiency risks that affect preterm and term infants differently based on their developmental needs and physiologic capabilities. Iron supplementation requirements vary dramatically by gestational age and clinical status. Premature infants require 2 to 4 milligrams per kilogram daily, beginning at 2 to 4 weeks of age, when erythropoiesis begins accelerating, while those receiving erythropoietin or darbepoetin need higher doses of at least 6 milligrams per kilogram daily to support enhanced red blood cell production. Term breastfed infants can rely on their substantial iron endowment until 4 to 6 months of age, when supplementation at 1 milligram per kilogram daily becomes necessary as stored iron depletes. Vitamin D supplementation remains universal at 400 international units daily for all infants, regardless of feeding method, though preterm infants with osteopenia may require higher doses of 800 to 1,000 international units daily for enhanced bone mineralization. Some studies suggest even higher doses benefit preterm infants, though 400 international units represents the established minimum. Vitamin K administration at birth prevents hemorrhagic disease of the newborn. Infants weighing more than 1,000 grams receive 1 milligram intramuscularly, while those below 1,000 grams receive 0.3 milligrams intramuscularly due to their smaller blood volume and muscle mass. Vitamin A supplementation shows particular promise for preterm infants, with research demonstrating associations with decreased bronchopulmonary dysplasia incidence when provided in appropriate doses. The physiologic basis for these different requirements stems from interrupted fetal nutrient accumulation, increased postnatal demands, and the transition from placental to enteral nutrition that occurs at different developmental stages for preterm versus term infants. Understanding the relative importance of topics for certification examinations allows strategic preparation that maximizes study efficiency. Parenteral nutrition management represents the highest yield topic for this section of the examination content, encompassing early initiation within 24 hours, appropriate component selection, including protein, glucose, lipids, vitamins, minerals, and trace elements, and vigilant monitoring for complications including cholestasis, line infections, and metabolic disturbances. Enteral nutrition types constitute a significant portion of content, focusing on formula selection based on clinical indications, standardized advancement protocols, and feeding tolerance assessment. Glucose management represents another major content area, emphasizing maintenance of appropriate glucose infusion rates, prevention and treatment of hypoglycemia and hyperglycemia, and understanding the critical minimum glucose requirements for brain function. Human milk and breastfeeding form a substantial component of the examination, covering composition differences between colostrum and mature milk, storage and handling guidelines, fortification requirements, and the limited contraindications to breastfeeding. Fluid management comprises a moderate portion of content, addressing requirements that vary by gestational age and clinical condition, factors that increase or decrease fluid needs, and complications of fluid overload or restriction. Nutritional assessment and special clinical conditions represent smaller but important content areas. Nutritional assessment focuses on growth parameters, anthropometric measurements, laboratory monitoring, and interpretation of growth velocity and Z-scores. Special clinical conditions include bronchopulmonary dysplasia, cardiac defects, short bowel syndrome, and necrotizing enterocolitis management. Study time allocation should prioritize parenteral nutrition management, enteral feeding strategies, and glucose homeostasis as the foundation knowledge areas. Mathematical precision in neonatal nutrition determines the difference between optimal growth and developmental catastrophe, making these calculations essential clinical tools. Weight gain assessment requires the formula: weight change in grams divided by current weight in kilograms, then divided by the number of days elapsed, yielding grams per kilogram per day. the standard metric for evaluating growth velocity against established targets. Glucose infusion rate calculations prove critical for brain protection. Multiply the percent dextrose concentration by milliliters per hour by 0.167, then demanded by weight in kilograms to determine milligrams per kilogram per minute, ensuring adequate cerebral glucose delivery while avoiding hyperglycemic complications. Caloric intake determination guides nutritional adequacy. Multiply feeding volume by kilocalories per ounce, divide by 30 to convert ounces to milliliters, then divide by weight in kilograms for kilocalories per kilogram per day, allowing comparison to established energy requirements. Macronutrient calorie calculations enable precise nutrition planning. Protein provides 4 kilocalories per gram, lipids deliver 9 kilocalories per gram, and carbohydrates contribute 4 kilocalories per gram, with these values used to calculate energy distribution and ensure balanced nutrition. 20% intralipid provides 2 kilocalories per milliliter, simplifying lipid dosing calculations and energy assessments. Dextrose contributes 3.4 kilocalories per gram, slightly less than pure carbohydrates due to hydration. These calculations transform abstract nutritional concepts into concrete clinical interventions, allowing precise titration of nutrients to meet individual infant needs while avoiding the complications of over or under provision that could compromise growth and development. These clinical pearls represent evidence-based guidelines fundamental to optimal neonatal nutritional management. The recommendations can be organized into several key domains of practice. Early nutritional intervention. Parenteral nutrition should be initiated within 24 hours for all very low birth weight infants to prevent negative protein balance and support critical growth during the immediate postnatal period. This early intervention is essential as the first week of life represents a critical window for preventing cumulative nutritional deficits that can impact long-term outcomes. Protein and glucose management. Preterm infants require a minimum protein intake of 3.5 grams per kilogram per day to achieve positive nitrogen balance and support appropriate growth velocity. Glucose infusion rates should never be reduced below 4 milligrams per kilogram per minute to maintain adequate cerebral glucose supply and prevent hypoglycemia. Feeding strategy. Human milk remains the preferred nutrition for all infants, providing optimal immunological and developmental benefits. Trophic feeding should be initiated early as it provides significant protection against necrotizing enterocolitis. Implementation of standardized feeding protocols has been demonstrated to reduce NEC incidence through consistent, evidence-based advancement strategies. Growth monitoring. Poor in-hospital growth velocity correlates directly with adverse neurodevelopmental outcomes. Head circumference growth serves as a reliable indicator of brain development and should be monitored closely as part of comprehensive nutrition assessment. These principles form the foundation of evidence-based neonatal nutrition practice. The integration of multiple evidence-based nutritional interventions creates synergistic effects that optimize outcomes for preterm infants beyond what individual interventions achieve independently. Early aggressive parenteral nutrition prevents the negative protein balance and metabolic complications that occur predictably in preterm populations without adequate nutritional support. Colostrum administration provides essential immunological factors and promotes beneficial gut microbiome colonization in the previously sterile neonatal intestinal tract. Minimal enteral nutrition stimulates gastrointestinal maturation and activates developmental pathways critical for normal intestinal function. Human milk contains bioactive components, including growth factors, immunoglobulins, and oligosaccharides that provide protective effects not available in synthetic alternatives. Standardized feeding protocols reduce practice variation and improve clinical outcomes through systematic implementation of evidence-based interventions. These protocols replace subjective clinical decision-making with objective, research-supported approaches to neonatal nutrition management. The complexity of supporting extrauterine development in preterm infants requires comprehensive understanding of developmental physiology and careful application of nutritional interventions. Preterm birth interrupts normal fetal development during a period of rapid growth and organ maturation, necessitating specialized nutritional support to optimize developmental trajectories. Clinical success depends on precise implementation of evidence-based protocols, while maintaining awareness of the physiological complexity inherent in supporting premature human development. Effective neonatal nutrition management requires integration of multiple therapeutic modalities to address the unique metabolic and developmental needs of preterm populations. A 1.2 kilogram extremely preterm infant is receiving TPN with 3.5 grams per kilogram per day of protein. What is the minimum amount of non-protein calories needed for optimal protein utilization? Greater than 30 kcal per kilogram per day, greater than 50 kcal per kilogram per day, greater than 70 kcal per kilogram per day. The correct choice is greater than 70 kcal per kilogram per day. This question is testing your knowledge of TPN composition requirements, specifically the relationship between protein intake and non-protein calories. This is the correct answer, because extremely preterm infants require at least 70 non-protein calories per kilogram per day for optimal protein utilization and accretion. Without sufficient non-protein calories, protein will be used for energy rather than growth. Greater than 30 kcal per kilogram per day is incorrect because this amount is inadequate to support protein accretion and would result in protein catabolism. Greater than 50 kcal per kilogram per day is incorrect because although this provides some energy for protein sparing, it remains insufficient for optimal growth in extremely preterm infants. For an infant with confirmed cow's milk protein allergy with significant GI symptoms, which formula would be most appropriate? Casein predominant formula, extensively hydrolyzed protein formula, soy-based formula. The correct choice is extensively hydrolyzed protein formula. This question is testing your knowledge of specialized formula indications, specifically for allergic conditions. This is the correct answer because extensively hydrolyzed protein formulas contain proteins that have been broken down into peptides, small enough to avoid triggering allergic reactions in most infants with cow's milk protein allergy. Casein predominant formula is incorrect because casein is one of the main allergenic proteins in cow's milk and would cause continued symptoms. Soy-based formula is incorrect because up to 40% of infants with cow's milk protein allergy also react to soy protein, making it an inappropriate first choice for significant GI symptoms. A 1,500-gram infant is receiving D10W at 6 milliliters per hour. What is the glucose infusion rate in milligrams per kilogram per minute? 4 milligrams per kilogram per minute, 6.7 milligrams per kilogram per minute, 10 milligrams per kilogram per minute. The correct choice is 6.7 milligrams per kilogram per minute. This question is testing your ability to calculate a glucose infusion rate, a critical skill for managing neonatal nutrition. This is the correct answer because the formula for calculating glucose is % mines % dextrose times milliliters per hour times 0.167 divided weight or kilograms. Applying this formula, 10 times 6 times 0.167 divided 1.5 equals 6.68, which rounds to 6.7 milligrams per kilogram per minute. Human milk that has been refrigerated at 4 degrees can be safely stored for up to 24 hours, 48 hours, 96 hours. The correct choice is 96 hours. This question is testing your knowledge of human milk storage guidelines, which are important for maintaining nutritional quality and safety. This is the correct answer because recent evidence suggests human milk can be stored at 4 degrees in a refrigerator for up to 96 hours without increased bacterial count and with minimal changes in macronutrients and immunological components. 24 hours is incorrect because this is unnecessarily restrictive and doesn't reflect current evidence-based guidelines. 48 hours is incorrect because while this would be safe, it underestimates the actual recommended storage time for refrigerated human milk. A 29-week gestation infant with bronchopulmonary dysplasia requires fluid restriction, the minimum fluid requirement to provide adequate nutrition while managing respiratory status is 60 to 80 milliliters per kilogram per day, 80 to 100 milliliters per kilogram per day, 100 to 120 milliliters per kilogram per day. The correct choice is 80 to 100 milliliters per kilogram per day. This question is testing your knowledge of fluid management in special circumstances, particularly for infants with respiratory conditions requiring restriction. This is the correct answer because infants with BPD typically require fluid restriction to 80 to 100 to reduce pulmonary edema while still providing adequate nutrition. To compensate for the reduced volume, caloric density is usually increased to 26 to 30 kcal per ounce. 60 to 80 is incorrect because this level of restriction would make it extremely difficult to meet nutritional needs and could lead to growth failure. 100 to 120 is incorrect because this may not provide sufficient fluid restriction for an infant with significant BPD and could worsen pulmonary status.